ECDC On Air,
the podcast of the European Centre for Disease Prevention and Control.
Keeping up to date with European epidemiology.
Welcome to ECDC On Air, the podcast from the European Centre for Disease Prevention and Control. My name is Caroline, and in today's Risk Wire episode, Bruno Ciancio is here with me. Bruno is the head of the ECDC unit dealing with directly transmitted and vaccine-preventable diseases. He will talk with us about diphtheria and why ECDC recently published a rapid risk assessment about it. Thank you for joining us, Bruno.
Thank you, Caroline. Hello, everyone who is listening.
To start off with rapid risk assessment, when you say that, in a nutshell, when and why does ECDC issue a rapid risk assessment?
ECDC main role is actually to assess and communicate infectious disease threats, and infectious diseases are posing significant threats to the European citizens, even today's, and particularly today's, due to mega drivers such as inequalities, the impact of climate change, the disruption of the health system caused by wars. So we are constantly trying to rapidly detect and assess possible infectious disease risk with the objective to inform member states of the European Union and recommend the possible ways to prevent the impact of such threats and control them in a timely manner. Since infectious disease can spread very rapidly across the globe due to very intense movement of people these days, timing is at the essence for our rapid risk assessment.
So rapid really means once you pick up a signal, you try to see whether you need to act.
It depends. Most of the times we can take some time, and it's important to gather the right evidence, involve also experts in the member states, consult our advisory bodies. But other times we really need to act quickly, and we can produce a rapid risk assessment within 24-48 hours since the event, if necessary.
Does it usually come that fast? And is this a decision that ECDC takes?
We have a mechanism, a daily mechanism, through which we assess all the ongoing possible events and threats to the European Union. And in this particular meeting, which gathers all relevant experts at ECDC, we take the decision whether we need to do a rapid risk assessment or not. This can also come at requests from the European Commission or from a concerned member state. So we really try to be timely and also relevant and try to understand also what are the type of evidence and type of advice that member states need from ECDC.
ECDC issued a risk assessment recently, noting ongoing transmission of diphtheria in Europe. So some of us might not know what diphtheria actually is, what it looks like. Can you briefly explain what diphtheria is?
So diphtheria is an infection that causes severe respiratory symptoms, and it comes with severe infection of the throat. It can involve also the nose, and the toxin produced by this bacteria causes significant damage, and it leads to the creation of very extensive inflammation and membranes that most of the times make the person unable to breathe, and this is one of the causes of death. In addition, the powerful toxin can spread actually and impact on important organs such as the heart, causing myocarditis, the nervous system, causing a demyelinization of the nerves, and the kidneys, causing kidney failure. So this is a very severe illness which used to lead to a mortality up to 10-15% of the cases with respiratory symptoms. It comes also with a cutaneous form, which infects the skin. This is usually a localized infection, not leading to systemic symptoms. It presents as a not healing ulcer that can go unnoticed because it's not very painful, and it can be also confused with other diseases. And so most of the times there must be the clinical suspicion based on some epidemiological factors Nowadays, it is most frequent in people who inject drugs, for example, or people that are very vulnerable living in very crowded conditions. Most of the cases, however, of the infections don't lead to disease, and there can be asymptomatic infections, and there can be also asymptomatic carriers of the bacteria, for example, in their throat.
So when you say carrier, that means I can have the bacteria without even knowing that I have them.
Yes, this is possible, but with the introduction of mass vaccination campaigns, the number of carriers have declined significantly, and several studies conducted in the past have shown that actually the level of carriage in vaccinated population is extremely low.
Mm-hmm. You mentioned that there might be respiratory forms and cutaneous forms. So what would be symptoms that, if not I myself, but maybe my doctor should be aware of?
Nowadays, this disease is very uncommon, and we see very few cases thanks to the vaccinations. At the same time, doctors should be aware of cases, particularly in vulnerable groups, including very old individuals or people living in a condition of homelessness, people who inject drugs, and people maybe who actually work to support vulnerable groups. They could, if they are not vaccinated, they could experience the disease. And in that case, the disease can manifest both with the cutaneous or with the respiratory form. And the doctor should be aware that this is a possibility, inquire, also collect a complete history of the patients, perform the necessary testing, and if there is a strong suspicion, even before having the results of the test, initiate the public health measures, including the contact tracing and the various therapeutic options that are necessary to treat diphtheria patients.
You mentioned that thanks to wider vaccination efforts, diphtheria has become rather rare in Europe. So what do I personally need to do, for example, to protect myself? Or is there nothing I need to do myself?
I think for the general population at the moment, we don't see any specific risk because vaccination has been in our primary immunization programs for a long time. We know that member states have a very effective vaccination programs for diphtheria toxoid containing vaccines. And this really led actually to almost elimination of the disease from Europe, to the point that most of the cases we have seen until 2022 were either imported or linked to imported cases. What we need to consider now is a slightly change of the situation.
When you say imported, that means, for example, I have traveled to a place and I got infected there and brought it home.
There are areas of the world where diphtheria is still a common disease. And if someone who is not vaccinated travels to this area, there is a risk of infection. And it is therefore always recommended to actually check the epidemiology of the places where we go and be vaccinated in case we didn't receive a recent booster for diphtheria, but also for other diseases that can be endemic in the places that we visit. So this is one way that disease can be imported, but it can also be by actual tourists visiting the European Union or other situations.
When we look at the evolution of case numbers reported on diphtheria in recent years, what is it that concerned ECDC?
For many years, we have seen very few cases of diphtheria, mostly sporadic cases. And we knew that there was very, very little risk of acquiring diphtheria within the European Union, thanks to the great efforts in vaccinating the population. In 2022, we saw an exceptional increase in the number of reported cases, which caught immediately our attention. And we started investigations together with the member states, and these investigations revealed that there was a specific group of the population that was affected. This concerned recently arrived migrants from different countries. And when we did the analysis of the genotypes, we identified very few strains that were affecting these people, indicating that they actually acquired the infections during their journey to the European Union. The outbreak was eventually controlled, so the cases have declined, but they've not disappeared. So we have continued to see cases also in 23, 24, 25. And while looking at the characteristics of these cases, we started to see also additional vulnerable populations being affected, including people living in a status of homelessness, people who inject drugs, people who work to support actual vulnerable people. And all these groups didn't report any contact with confirmed case, which means that they acquired the infection in the community. This, of course, indicates that there is some degree of circulation of Corynebacterium diphtheria in the general population, which means that we need to protect the groups that are most likely to develop disease if in contact with the bacteria. The infections are ongoing. We have seen cases in 2023. We have seen 56 cases in 24. And in 25, until now, we have seen around 15 cases. So this is something that is not over yet.
If everyone is vaccinated, if we are seeing the numbers going down, why risk assessment now about diphtheria?
I think we should not focus only on the numbers. It is true that if you consider the whole European Union, the number of cases that we have seen between 23 and 25 is not big, but we still count more than 200 cases. But it's more like the nature of these cases. Most of these cases are people experiencing homelessness or intravenous drug users or people that have contact with these risk groups and vulnerable groups. They acquired the infections from the community, so they didn't have any known contact with a positive case. And this indicates that there is some degree of transmission of Corynebacterium diphtheria in the population. And thanks to the high level of protection given by vaccination, we see low numbers. But at the same time, we know that certain part of the population could be more vulnerable to infection and to disease. And we also know that these people are also less likely to be updated with their vaccination. Let's not forget that the diphtheria vaccine produces a very high effectiveness against disease, but this effectiveness tends to wane over time, and people that are old and people that have not received the full vaccination course or that have not updated their vaccination schedule, they could still be at risk. And therefore, the reason why we're worried is that we would like not to see any circulation of toxigenic Corynebacteria in the population of the EU. If there is circulation, there will be a risk for certain group of people. And speaking of timeliness, we need to do the risk assessment now so that measures can be taken to prevent further cases from happening.
I understand that there's a specific bacterial strain or sequence type. Overall, the number of identified cases with this sequence type does not seem to account for a lot of cases in recent years. Why is a specific sequence type kind of some part of your rapid risk assessment worry, so to speak?
We don't know exactly why there is one specific type that has been circulating recently. Most likely this has to do with some virulence factor associated with this particular strain. What is important, however, from the molecular data and the fact that it's one strain, it means that there is circulation. I mean, this specific strain has been detected and isolated from patients that are far away from each other, and they don't know how they got the disease. This is the proof that there is some degree of ongoing transmission, which is very difficult to quantify, but I think we have enough data to really give some recommendations, both to the doctors and to the general population. This is the reason why we decided to issue rapid risk assessment on this occasion.
You're seeing signals of transmission, and as you said, ideally, we wouldn't want to see any cases of diphtheria in Europe. How would you want countries, individuals, doctors to act now?
I mean, my first recommendations is really to use any opportunity health encounter, contact with people that are known to be vulnerable to the disease, to use any opportunity to give them the possibility to be vaccinated. The second important recommendation is for the clinicians. It is very difficult to make a diagnosis unless you have the suspicion. And so we would like to make sure that doctors consider the possibility of diphtheria when they see someone with severe throat infection belonging to these groups that I mentioned, and also particular attention to lesions of the skin that can reflect cutaneous form of disease. If they have the suspicion of a diphtheria infection, they need to rapidly perform the test, so they need to know in advance what test should be performed. They need to initiate treatment. They need to contact the public health authorities for initiating contact tracing. And in case of positive results, then close contacts will need to receive prophylactic antibiotic treatment. And they need to be tested, of course, to verify that they didn't got the infection. In addition to this, we need to make sure that vaccination programs continue to be very effective. So any effort should be made to ensure very high vaccination coverage in the population. This includes the primary course, but it also includes the administration of regular boosters as needed.
How many doses of vaccines I need to be protected? And when would I, for example, need to check if I'm up for a booster dose?
Vaccination for diphtheria is given very early in life and comes together with vaccination for tetanus and pertussis. Most of the doses are administered during the first 15 months of life, the first 3 doses, and then subsequently at school entry, and then there is most of the times a booster also in adolescents. Thereafter, boosters are recommended every 10 years.
You mentioned treatment of diphtheria. What does that look like?
Respiratory diphtheria requires a combination of treatments. There is the availability of an antitoxin, which must be administered very rapidly following the diagnosis. And this is very effective and can prevent the most severe consequences of the disease. The other very important therapeutic intervention is the use of antibiotics. Antibiotics will basically reduce the duration of the infection, stop the bacteria from producing the toxins. Of course, severe cases will require to be treated in hospitals, and there will be also a lot of support care needed. Cutaneous infections are treated effectively with a course of antibiotics.
Is this treatment readily available for everyone?
The diphtheria antitoxin is something that, due to the very low number of infections, at some point was only available in few countries, and it was extremely challenging to organize rapid delivery of the antitoxin anytime there was a case in Europe. We tried to address this problem by ensuring that the antitoxin continue to be produced. And there are now agreements between the countries and the European Commission for a joint procurement of the diphtheria antitoxin, so that member states can have availability of antitoxin within their reach when needed.
Compared to measles, for example, where we had more than 33,000 cases last year, diphtheria has a lot lower case numbers reported. Both can be prevented by vaccination. Can you explain a little more what the best prevention is, both for measles and diphtheria, and why the amount of cases doesn't necessarily say anything about the severity?
All vaccine-preventable diseases can reemerge as soon as there are problems with vaccination coverage. Measles has actually emerged as a substantial threat in Europe, but in other countries such as the United States and Canada in the last few years. And this is a significant event. Measles is a severe disease which causes important consequences for the children and can be fatal. It's the most transmissible of the vaccine-preventable diseases. It means that if someone with measles go into a room where there are some susceptible people without protection, without vaccination, they will get the infection, even hours after these individuals left the room. So infectious is measles. which means that it's very challenging to control. We need to reach very high level of vaccination coverage. We need to go above 95-97% of the population coverage for controlling measles. And this is one of the biggest challenges we are facing in the EU, and not only. For diphtheria, the situation is different. Diphtheria is very transmissible, but not as transmissible as measles. There is the possibility of asymptomatic carriers and infections as well, which means that there can be a persistent risk of infection, but mostly for people who are very vulnerable, who did not manage to receive a vaccination booster, etc. So for measles, 2 doses of vaccines are extremely effective. They are given during first years of life, and they provide lifelong protection. For diphtheria, the vaccine is equally effective against disease, but it requires some boosters. And this may expose some part of the population to the risk of infection.
So the best thing we can all do is check our vaccination status.
Yes, and also don't forget those vulnerable populations.
Thanks for joining us today, Bruno.
Thank you, Caroline.
Thanks for listening to ECDC On Air. And remember, vaccines work. Get vaccinated, check your vaccination status, and if you're unsure, check with your healthcare provider and GP. And if you have any comments or thoughts, share them with us online.